So what does the future promise? This was my topic to cover. And I brought you only a few things, because the future will bring a lot of new things, but I want to emphasize a few topics which are also known already, but will make the future much brighter and the treatment will change. So what we will have in the next 3 years, we will have new diagnostic options. We know from screening, and screening is an old story, but still is very important, because when we want to heal cancer, we need to find cancer very early. But the problem is, when we find it very early, and we know it from screening, it works, we can lower the overall mortality. However, we have a significant overdiagnosis and overtreatment. And this is the problem we are facing today, and we will face in the next years. And when we look at the studies and the updates of the studies, we will see that the curves divide even more in the years. So the screening is good on one hand, but on the other hand has a significant overdiagnosis and treatment. And because we are facing this problem of overdiagnosis and overtreatment, we have to change our thinking on the diagnosis of prostate cancer. And we all know, and we are all aware of that. We have the Gleason 6 problem, and which is very new and upcoming, we have the prostate cancer genome. And from these things, we will find new diagnostic and also treatment options. When you look at this curve, what you can see here is the light gray bars and the black one. The black means people are dying from prostate cancer. The gray one means you're diagnosed by prostate cancer, but you will not die on it. So what we have here in the upper part, these are the Gleason 6. And when you look at the Gleason 6, we find a lot of cancers, but only few people will die on the cancer. So what we have, we found someone who has cancer, we title it cancer, it's a prostate Gleason 6 cancer. We have all the fears, all the frightens which comes along with the diagnosis of cancer. From the statistic, it's clear. If you have a Gleason 6 and you're a 65-year-old and the diagnosis is correct, and this is one of the problems we have, then the chance that you die on this cancer is very, very low, which means you don't have to treat it. This is where active surveillance comes in. This is for sure and for clear, and the evidence is also clear. You don't have to treat these kind of cancers. However, we have the problem with diagnosis. We have the diagnostic dilemma. Is this really a Gleason 6? We have problems with pathology. We have problems with the biopsy course, etc., etc. So this is why we want to clear up our diagnosis. But still, we know that this is a problem. On the other hand, if you look down here with a Gleason 8 and you're 65 years old, you have a very high chance to die on your cancer, even you have a radical prostatectomy or radiation therapy. So in these kind of cancers, we are too late. In these kind of cancers, we are too early. So we have to find a way out of this dilemma. So, is Gleason 6 is a hot topic? Yes, it is a clearly hot topic, and we need the help of our pathologists and other features to clearly say, is this a cancer or not? You cannot go for a diagnosis, go for a biopsy, then you find Gleason 6 cancer, you call it cancer, and then tell the patient, okay, probably it's a cancer, but you will not die on it. So we have to clear our diagnosis on this topic, that we have a clearer language, that we can discuss it with you on a much clearer way. Otherwise, we all have the doubts, and then you go for a second and a third opinion, and there are 3 urologists, and everybody tells you a different story. Yeah, you have to be afraid, you have upgrading, blah, 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 and so the other things. And you have seen this slide already. This is very interesting because we already heard Gleason 6 is, you cannot die on Gleason 6. But on this study, which is really published in a very high journal, you see this is a radical prostatectomy specimen. What you can see here is reality. We have a lot of foci of prostate cancer. There are 7 foci, 9 foci of prostate cancer within this prostate. And all of these foci have a different type of cancer which is in the cells. So when you look at this, you find this spot. This is a P1, a very small one here. And you have seen in the primary tumor that there were some mutations already. And what you look at this story of this one patient, but you can learn a lot, is he had a radical prostatectomy, and then it took 17 years till he got biopsies, and actually he died on this cancer after 17 years. Even this was not such a very high cancer, it was Gleason 7 on biopsy, but he died actually on this Gleason 6 cancer on the P1. And this is found by this analysis, and the lung metastases were from the Gleason 6 area. So this is somehow a problem. We said it's not, Gleason 6 is not a cancer, but then we have this publication. So we have to find out, is this really Gleason 6 or not? What is Gleason 6? A pathologist looks in the microscope and describes the cells. This is all he's doing, and it's not very deep in the biology. We don't know the biology. It's only the behavior of the cells. So when you look at this patient again, you see where the metastasis came from, and it was a very young patient. Yeah, at the diagnosis, so he was 47 after 17 years. He is 64 years old, still too young to die. So it was in 1995, it was a Gleason 7, but it was an extracapsular extension, and he had primary metastasized prostate cancer at the time of diagnosis. So lymph nodes were positive. Like in all prostate cancer patients, he died with a castration-resistant prostate cancer. So this is the end stadium of the prostate cancer. And they have done, from this metastatic sites, they took a warm biopsy and did a sequencing and molecular profiling of the whole genome. And this is why I put it slide in. This is the future. This is something we want to do maybe in the next years for our patient in advance, not after 17 years at the primary diagnosis, to see which of these foci will probably kill the patient. So this is something we know. Have we tools? Yes, there's probably some tools around in the literature. How can we do it today or in the next years? We have changes on the chromosome 8, and we have the P10 loss, which is a mutation which you can measure, and you can ask for the pathologist to measure it. And when we see, if you have this biomarker constellation, you have a more common chance to have not a real Gleason 6 prostate cancer. So if you are diagnosed by Gleason 6 and the pathologist can tell you there's a P10 loss or something like that, then the probability increases that it's not a real Gleason 6. It's a more aggressive cancer. This might be a tool for the future to help us with the Gleason 6 dilemma, what we have today. This is how it looks. You can do a staining of the cells, and the pathologist says, okay, there's a P10 loss, he has problems with the chromosome 8, and so on, and then it might trigger therapy and not active surveillance in this kind of patient. What is the next step? We have to go into the molecular taxonomy, and what we know from this genome, prostate cancer genome studies, is that there are 7 mutations, which you can read here, but it's not so important for you now to hear all the words and then also listening, because I'm also a urologist, I'm not a genetic. So don't want to go too deep into this, but we know already that there are 7 mutations. And when you look, you can go and see the genomic complexity of this primary human prostate cancer. And when you look at this, there are again these 7 genes, and you can see complexity and correlation of that. And maybe this will help us in the future to better differentiate which kind of tumor is to treat and which kind of tumor is not to treat and how to treat. And what we found from this prostate cancer genome already, And maybe it's also called the stone of Rosetta, and you know this stone helped us to identify the hieroglyphs, to translate the Egyptian language into our language today. And maybe we have with this prostate cancer genome a tool where we better understand the biology of the tumor. And what is already found from this genome studies is that we know and we are aware today that 2 of 3 patients with prostate cancer have mutation in the androgen receptor. This leads to a better understanding of the primary hormone resistance, which is very hot topic up to date, because we are with all new targets, we know about 20 to 30% have a hormone resistance because of mutations in the androgen receptor. But on the other hand, what we also have learned is 1 out of 4 patients, this is very new, they have a mutation in the breast cancer gene, in the BRCA1 and 2. And this is a possible new target to treat these type of tumors. And this is with the PARP inhibitor olaparib, which is already on the market, and it's for ovarian cancer, and studies are ongoing for prostate cancer. And maybe these genetic tumors, they have normally a positive family history, might be better treated with PARP inhibitors than with ENZA or ABI or others. So we will see that. We also have found mutations of the RF gene, which is a target for the TKI sorafenib. This is a possible new treatment option, and we have also mutations in the PI3K, which also medication are already on the market, and studies are ongoing, and we will hear in the next years how these new targeted drugs will help us to treat prostate cancer in the treatment settings. So what we know already, and you have seen this slide already several times, maybe in the morning, but this is the STAMPEDE trial, and what we have learned from the STAMPEDE trial is that patients with a primary metastasized prostate cancer diagnosed, so it's an aggressive form of prostate cancer regardless of the Gleason score, otherwise it would not have been metastasized, is that these patients will live long. And from here, this is a failure-free survival, the green one, which means from this somewhere he had a failure. From that time he is castration resistant, and the most time in their life, at the end of their life, they live in the castration resistant setting. And when you see the median survival in the STAMPEDE trial was already 42 months. So people live quite long, but if you are the patient, you want to live even longer, not 42 months, you want to live actually 140 months or 240 months if possible. So we have to prolong it. If you're a patient here and you died already after 6 months, that means our treatment was not good. And you have seen this also, this is a charted trial, and we separate now the primary metastasized tumors which we find, and this is a subpopulation in high volume and low volume disease. This is one definition of high volume was in this trial with visceral nodes and so on, but this is something which goes on. And finally we divide it, and in high volume we know that primary docetaxel chemotherapy is the upfront therapy. In low volume it's not so clear, as Professor Kramer told you already. He's treating everybody because it's also stated in the EAU guidelines, but follow-up data from this study from the charted trial was presented last year at the ESMO, showed that in low volume the difference is not so good. So this is questionable if you will really benefit from an upfront chemotherapy in this setting. So, are there new hormonal agents move early? And I was asked to talk about the future, and I would show you the future already started 4 days ago at the ASCO meeting, and the Latitude study was presented. You also seen the slide already. This was a randomized trial of ABI in the early setting of high-risk prostate cancer, primary metastasized, and these were Gleason 8 cancers or higher, more than 3 bone lesions or visceral lesions already. So this is a very aggressive form of tumor, primarily diagnosed in this metastasized setting. So what they have evaluated is if ABI will work in the setting, and they randomized it to normal hormone therapy. And what they have shown in this is clearly patients were good balance in both studies. So from the methodology, it's a good study. And what you see, you have a 38% risk reduction of dying of prostate cancer. And what you can see here, again, is when you're on treatment in this early setting, you will live quite long. This is the median. It's not reached now, so I don't know when the curve will go down, how long it will take. But again, we have this 4, 5, 6 years when you're on therapy, even if you are high risk primary metastasized prostate cancer. So the future starts with that. Then what you see here, this is something with PSA, and you have also a 70% PSA progression reduction, and you see the difference, 7 months or 33 months. And when you are the patient and you go for PSA every 3 months, it makes a big difference if your PSA rises again after 7 months or after 33 months. Because you will also will not be affected so much by the PSA values in your quality of life. Pain progression also very important. It's not even that you will live longer, you will also have the chance to live with a better quality of life, with less pain when you're on treatment. This is very important. So the classical hormone therapy in primary metastasis prostate cancer is dead. Yeah, you go for ABI or you go for docetaxel, but only for hormone therapy it's actually dead. And you also have a 53% risk reduction of radiographic progression, and this is very important. And also the chance that you get a second-line therapy, maybe chemo or other treatment, is also lowered by 58%. So the time period is much prolonged, and what you see here, all the second endpoints and the primary endpoints were positive within the study. And this was true even for patients who had visceral metastasis, so liver or other metastasis as a primary diagnosis. So this study is for sure will change our policy within the next months and years. This is for sure. And this is treatment. On the other hand, costs and everything is also important, but this, I'm a urologist. I will talk first of the opportunities. I'm not in the health system. The politicians have to solve the problem with the costs. So the conclusion is that we have already now good medication in this setting of primary metastasized prostate cancer, which is very aggressive by itself. Do we have new strategies they have to be developed in the next years? This is clear. We all go, and we heard it already, we have to go for molecular diagnosis and treatment. We will not go, as you have heard already with the BCR gene mutations, for example, that you can take a medication for ovarian cancer for prostate cancer too. Because it's not the organ by itself which leads us to the therapy, it's the biology or the molecular key points behind the disease which will decide what kind of treatment decision and options we have. And not so much, this is prostate and one fits all for everybody. This is something, this will clearly change in the next years. Hopefully not in the next decade, maybe earlier. And we heard, and very promising data comes from this prostate cancer genome project, and what we will learn is that we have to detect the cancers earlier in their environment, and we have to treat them with a targeted, individualized therapy and not one fits all. Thank you very much.